Thank you all for joining us this afternoon for the second health seminar of the Indian Cultural Association of Minnesota. I'd like to start by acknowledging Dr. Suresh Koragal. Many of you know him already. I would like to thank him for his vision and support. He was instrumental in actually leading this initiative and was responsible for organizing the first event last year. The purpose of the Intercultural Association of Minnesota is to connect, communicate, collaborate, and create a platform to serve and support the cultural and educational needs of the Indian community. I'm Seema Kumar from the ICAM Health Committee. I would strongly encourage you to become a member of the ICAM or volunteer if you have not done so. I'd like to introduce Ajay Singh, President of ICAM, to say a few words. Ajay.
Thank you so much, Seema. Thank you to the whole committee, Sandhya, Kavita, Nisha, Anjali. Awesome work in this health committee, and great to see you guys all taking a lot of active role in moving forward this committee, and very proud of the team to put together this another health seminar. You know, the COVID has changed our life, and the reason why the health is so important. We can all celebrate our culture, come together, and you know, for last 2 years we had been doing all this virtual. We were not able to meet in person, and we are hoping this year we will get an opportunity to meet in person. So that is the reason why, you know, we ICAM put together, you know, a vision to have a, you know, health committee which provides all the information and the benefits to the community so that they are strong and healthy, and our culture, they can be participate in our culture. We can continue doing more cultural activity, and we can all celebrate in person. This is the second year of ICAM, and I think we have done a lot in 2 years. We were certified by IRS to be 501c3 status approved. And then we had a 2 Diwali culture program. We had a major ICAM Utsav annual event last year. We got a first grant to get everyone vaccinated in the community. So I request everyone, I know in this, people who are in this call may be vaccinated, but we need every help to get other people. They might be there's still 30% out there who are not vaccinated. Educate them, tell them, you know, how they can be vaccinated. We, ICAM, will provide all the assistance for them to be vaccinated. We continue to partner with various organizations. We have partnership with the IMAA. We have a partnership with Asian Media Access, Diversity Council, and various other organizations. We have partnership with the IMAA. We have a partnership with Asian Media. Sorry, we're seeing some background noise. So a lot of plans. We have a lot of plans this year. We hoping that, you know, in this year we might have an in-person event. We are still working on some logistics where we can have some professional singers, performers, dancers who could either do virtually. If things still doesn't go well, they could do virtually, or we can do an in-person event. And thank you again to this committee. Thank you to the team. Thank you to the ICAM board members, and thank you to the speakers today to make this a very successful event. I will turn it back to Seema. Thank you.
Thank you, Ajay, for your leadership, commitment, and passion. And thank you from our side to the whole ICAM board members as well. Now I'd like to introduce Dr. Sandhya Pruthi, who will be moderating today's sessions today. Most of you know her already. She has been a very active member of the Asian Indian community for the last 26 years. So just a little bit about Dr. Pruthi. Dr. Pruthi was born in Uganda, East Africa, and then grew up in Winnipeg, Canada. She went to medical school at the University of Manitoba and then came to the US for a residency in family medicine. She is an internationally recognized breast health expert for the last 25 years. She is married to Dr. Rana Pruthi and has 2 sons, Shiv and Neil. For fun, she enjoys yoga, traveling, puzzles, and needlepoint. And I hope you will all enjoy today's talks. I'll hand it over to Dr. Pruthi.
Thank you very much, Dr. Seema Kumar, for your leadership, and to all of our ICAM Health Committee members for the time that you've all spent in the last few months. We sincerely appreciate your dedication, your time on the committee, and then contributing in many ways to help bring this important health committee together and the talks that we are assembling for all of you. But more importantly, I think we want to really recognize and are grateful for our presenters who are with us today to share not only their expertise, but their Sunday afternoon to help educate you, all of you, our committee, our community, and all of you to have chances and an opportunity to ask them questions. So what we will be doing today is, as each speaker gives their presentation, we have time at the end of their presentation for you to ask questions. So please take time to enter your questions in the chat, and I will be looking at them, and at the end we'll be asking the presenter to respond to those questions. At the end of the session at 4:45, for those questions that didn't get answered for a specific speaker, we will have time. So please remember to go ahead and enter your information, your questions in the chat, and I will be capturing them towards the end of the program. As well, as I mentioned, the ICAM committee really does value all of your thoughts and suggestions for future topics and presenters. So we are going to be posting in the chat a survey. This is asking you as participants, what are health topics that are of interest to you that we can bring at a future session to all of the community? We also want to hear from you about the frequency at which you would like to have these sessions. They are important. We know that they're valuable, and all of you hopefully can learn from our speakers and our topics, but we also want to know how frequent you want this type of information shared with you. So please take a few minutes to answer the survey. Ron will be posting it in the chat box for you to answer. So I want to go ahead and introduce our first presenter for today, and it gives me great pleasure to introduce Dr. Rana Chakraborty. Dr. Rana Chakraborty is a pediatric infectious disease specialist. His clinical focus includes expertise in the management of HIV in children and perinatal infections, and also the management of infectious diseases in children following bone marrow and solid organ transplantation. Dr. Chakraborty is NIH funded, and he has a laboratory that investigates the impact of maternal infections on exposed infants. Some of the pathogens of interest in his work includes HIV, cytomegalovirus, the Zika virus, and more recently, the severe acute respiratory syndrome that's associated with the coronavirus 2. So I'm going to go ahead and turn it over to Dr. Chakraborty, who will be pulling up his slides. And welcome, Dr. Chakraborty.
Thank you. I'd like to thank yourself, Dr. Kumar, and the committee for the opportunity to speak today. I've just started to share my screen. I hope that's coming through okay. Great. And today's talk is, as advertised, COVID-19 vaccination in your child, balancing the risks and benefits against the 24 letters of the Greek alphabet. I apologize from the outset if some of my descriptions are a bit technical. That's always inadvertent, but I'll try and be as clear as possible, and obviously happy to take as many questions as possible towards the end. So today's objectives are to describe the epidemiology of the pandemic with a focus on its impact on children here in the United States, to talk about the life cycle of SARS-CoV-2, the pathogen that causes COVID-19, and how physicians and scientists over the last couple of years have identified active immunologic strategies, specifically immunization strategies to prevent infection in populations. To talk about the risks and benefits of SARS-CoV-2 vaccination in children. And then I'm also going to talk a little bit about what we're seeing the picture in India. I'll obviously be talking about investigational vaccines in children. However, I have no financial disclosures about any of the products that I'm going to be talking about, or for any other product for that matter. So going into the epidemiology, children and COVID-19, and what we've witnessed over here in the United States the last 2 years. As you're all aware, there's been a lot of descriptions in terms of hospitalization, morbidity, and death. Then we've had this strange syndrome called multisystem inflammatory syndrome in children, which has also been characterized in young adults. And we've also seen long COVID associated with the long-term sequelae of acquiring primary infection, and that's also been characterized in children. However, behind that, there's also other hidden pandemics. And obviously, a half-an-hour talk on the Sunday afternoon doesn't and won't do justice to the impact that the pandemic has had on the education of children, not only here in the US, but globally. The impact on their mental health, the financial stress that their parents and caregivers have had to bear, and how that's also impacted their long-term outlook. And there have been other impacts on pediatric health during this time. I'll go into some numbers, but obviously you may not want to get hit with a load of epidemiologic numbers on a Sunday afternoon, but broadly in the United States, it's about 75 million children. That's the pediatric population. We've seen close to about 8 million cumulative cases, and this is as of the 31st of December, 2021. And that means about 17% or so of the total number of cases compared to adults. So it's not insignificant with that many children acquiring SARS-CoV-2 infection or COVID-19 in the last 2 years. And those numbers are continuing to rise, as shown by the plot over here. And so this is more a reflection of the emergence of Omicron variant. We've had various peaks that have reflected the surge with the Delta variant. And we've seen other peaks as well with the Alpha and Beta. But certainly, given the infectious nature of Omicron, our numbers are really, really marked. And this has been particularly the case over here in Minnesota and also Michigan. This is some data in pediatrics for the month of January. And again, you can see the huge impact reflecting the infectiousness that the Omicron variant has in terms of its ability to spread through human populations. The line is very much vertical with all age groups, and the yellow is for the pediatric age group, but the purple over here is for those 70 years or older, and the pink for those between 60 to 69 years. You can see the trend is very much up, and I suspect eventually January, February, March, we're going to go above what was witnessed in January 2021. More locally over here in Minnesota, the picture is pretty much the same, very much an upward trend, both statewide in terms of absolute numbers of pediatric patients developing COVID. And in total, as of data from December the 29th, 2021, there have been over 800 deaths in the pediatric population. These are the numbers between 0 to 4 years and the numbers between 5 to 18 years. And I know that's really a tiny, tiny fraction compared to the 814, 815 or so thousand individuals who have died in the United States from COVID. And there is also emerging data basically with long COVID in children and adolescents. And some of the initial data has come out from different investigators in the UK, but also Switzerland. We do desperately need similar data coming through epidemiologically on the impact of long COVID. And long COVID are these signs and symptoms that appear to develop. Their post-infectious symptoms, which occur weeks or months after the primary infection with SARS-CoV-2. And there's a multitude and plethora of different clinical manifestations that patients are experiencing. And unfortunately, we're also witnessing that in the pediatric population, and management is still emerging in terms of what is the best evidence base to provide the best quality care to these patients. And these are the numbers in terms of that inflammatory syndrome that I mentioned by jurisdiction. Our numbers over here in Minnesota are significant, but obviously not as high as what we witnessed in southeastern United States in terms of numbers of cases of inflammatory syndrome. And in total, we've seen 55 deaths from this particular condition. I'm going to talk a little bit about the life cycle and the pathogenesis of SARS-CoV-2 infection, if I may, because if we're going to talk about vaccination, it's important to understand what exactly is going on in terms of how the virus infects the human and how these effects go on to change our immune system. So this is the virus. You've heard of the spike protein, and I'll talk about this quite a bit in the rest of my talk. And this is sort of on the outer lining of the virus. Most of the acquisition takes place here in the nasal epithelia. There are nasal epithelial cells, and they are important because they have host receptors that can actually meet and interact with the spike protein. And this is sort of magnified in this illustration here. Those receptors are ACE2 and TMPRSS2. Don't worry about learning those now. But they interact with this spike protein and invite the RNA from the virus intracellularly. I need to take you back to basic high school or 10 or 10+2 biology. This is the cytoplasm. And this virus is invited inside the cell. And thereafter, it forms a vesicle and allows release of its RNA, which is its important genetic material. And I will keep talking about RNA and DNA. And then that's converted or translated into proteins. There's then viral assembly all taking place in this epithelial cell. And then after assembly, the virus buds off from the outer membrane and goes on to infect other host cells. Now, if this virus manages to make its way into the bloodstream, which invariably a number will, so this is the viral stage that I described here. But if this virus gets into the bloodstream, it's going to interact with these immune cells that we have in our body, or antigen presenting cells, which chop up bits of the virus which are expressed on the outer membrane of these antigen-presenting cells. These cells then interact with other immune cells called T helper cells, and they cause T helper cells to try and kill the virus, which is protective. But by doing so, it causes an outpouring of inflammation, which is what promotes some of the clinical manifestations that we have when we get SARS-CoV-2 infection or COVID-19, like fever, runny nose, sore throat, and so on and so forth. But at the same time, it interacts with B cells, which produce antibodies, which are also protective for us. And it's those antibodies that we've exploited in vaccination. Again, I don't want to get too technical, but scientists have really spent time in the last 2 years trying to understand the spike protein very, very closely. And part of it includes this thing called the receptor binding domain, which is where it meets those receptors that we have in our bodies, TMPRSS2 and ACE2. And why that's important is because when one individual gets infected and another one and another one, and there's a multiplication of individuals across a community, then across districts and counties, and then an entire country, and then other countries to cause a pandemic, our own immune system to some extent molds that virus. And that's exactly how variants emerge. And so this was very nicely and very beautifully articulated in a recent paper that I think is already published in Nature, where they show how all these variants in this receptor binding domain show mutations and allow different mutations. And those are highlighted over here with the Omicron variant. And why that's important is because our own immune system may not be able to identify the next variant. And that has ramifications in terms of how protective vaccination will be and how protective our previous infection will be once we produce those antibodies. Let's talk about some of the vaccines that are out there. So at the beginning of the pandemic, there are about 194 candidate vaccines that emerged, and they exploited different technologies. There were a few that tried to use bacterial antigen spore expression vector, but these really fell by the wayside. And there are no such vaccines now, COVID vaccines, using that technology. Nucleic acid, in other words, the mRNA technology that's been used by Pfizer and Moderna, as you're aware of, that uses nucleic acid technology, and they went into phase 1, 2, and then eventually 3 vaccines are out there in phase 4, which are in use in human populations. There are viral vector vaccines. I'll talk about that next. Whole virus and then protein-based vaccines. To some extent, a discussion on COVID vaccines, it's important to talk about the different types of vaccines because they use different technologies and they have different strengths and weaknesses. So the whole virus vaccine is often live, attenuated means changed, and it has a weakened form of the virus that can still multiply without causing illness. However, the downside with using this platform is that it can still cause illness in individuals who have weakened immune systems. And it also requires cold storage. Other whole virus vaccines are inactivated and their genetic material is removed, so the virus can no longer multiply and make copies of itself, which is good. So this type of vaccine can be given to immunocompromised hosts and doesn't require cold storage. There are protein subunit vaccines, which basically chop up pieces of SARS-CoV-2 to trigger an immune response. That minimizes side effects, but often they need to be boosted with what we call adjuvant proteins to boost or strengthen the immune response. An example of that is the hepatitis B vaccine that many of us have had. And then there are the nucleic acid vaccines that I've mentioned. And what happens here with the mRNA and with the Pfizer vaccine or the Moderna vaccine, which I'm sure many of you have had, is that you basically put in messenger RNA or the genetic code, and that's what gets put into your arm, your deltoid muscle. That then translates into the spike protein. Your body, your B cells are floating around, they recognize the spike protein, they say, well, this shouldn't be here. And they produce antibodies against spike protein. And pretty significant numbers following initial challenge. And then when you're vaccinated again, a second or third time, you're increasing the antibody levels in your bloodstream so that if you actually meet SARS-CoV-2, the coronavirus, there's going to be a lot of antibodies pre-prepared in your bloodstream. And although you can get infected in the nose, remember the nasal epithelial cells that I mentioned, and you can get cold and upper respiratory tract signs and symptoms that mimic a cold or that cause a cold. The good news is that it doesn't actually cause too much inflammation in your bloodstream. And it's been clearly protective against invasive disease like pneumonia. And then there's also the viral vector vaccines, which have been exploited or used by investigators at Oxford and also at J&J. And here what they do is they get adenovirus, which causes disease in chimpanzees, but doesn't cause disease in humans. So it's harmless to us. And this is a carrier, and it carries the nucleic acid, the RNA, into our own cellular machinery, hijacks it to produce protein and to trigger an immune response. And again, those nice antibodies that are around in your bloodstream. And so with that, we've now had the clinical data coming out in some of the papers. And so this, I'm not going to talk about the safety and immunogenicity in adults, but certainly in adolescents late last year, we had this paper out. The take-home message was that the Pfizer vaccine, given in 12 to 15-year-olds, had a favorable safety profile, produced a greater immune response than in young adults, was highly effective against COVID-19. And here what they used, it was a phase 3 study. They used 30 micrograms as the dose. They found they had very strong antibody responses, better than what they found in 16 to 25-year-olds. The side effects included fatigue in a lot of patients and also headache. But the effectiveness was 100%. And then they made some comparisons between with lower doses. What they then did towards the end of 2021 was say, okay, well, this seems to work in those above age 11, children above age 11. What about the 5 to 11-year-olds, especially those attending elementary school? Again, using the Pfizer vaccine. And the take home was that when they used 2 doses of 10 micrograms, given 21 days apart, this was safe, immunogenic, and effective, efficacious in this age group, 5 to 11-year-olds. Matter of fact, they used that lower dose, and the antibody response was similar to 16 to 25-year-olds. Yes, there was injection site pain. Yes, there was fatigue, tiredness, and yes, there was headache. But the vaccine efficacy or the effectiveness was 91%. And that's shown quite elegantly over here, where they compared a similar group of children who received placebo, age 5 to 11, and their risks went up close to by 2.5 times compared to the group that received the actual vaccine. With that, there's now been discussion about, well, what about those who are even younger than 5 years of age, from 6 months to age 4 years? And so there is a phase 1 study. They're using a much smaller dose, 3 micrograms. They're using 2 doses. And their age groups are from 2 to 4 and 6 months to 2 years. Up to now, the antibody response for this group, 6 months to 4 years, was non-inferior to 16 to 25-year-olds, although that wasn't the case for 2 to 4-year-olds. And we're expecting results in the second quarter of 2022. So the data isn't quite published yet, but again, this is looking quite optimistic. We'll just have to see what if there are any issues in terms of side effects. And some of the scientific evidence that we've used sort of neutralizing antibodies against to look for protection against the Omicron variant with this Pfizer vaccine. And you can see that 3 doses clearly is more protective than 2 doses. And this was the justification about why we went out and suggested that after individuals, not only in the pediatric population, but the adult population in the US, after they receive 2 doses, that why they should go out and get the 3rd dose, this particular graph here. Of course, it's not all been fantastic. There have been issues that are of concern. In Israel, they've had an excellent epidemiologic unit that's been able to characterize side effects. And one of the things that investigators there reported was the incidence of myocarditis, in other words, inflammation of the heart lining and the heart muscle. This was, although low, it did increase after the receipts of this Pfizer vaccine, particularly after the 2nd dose. And this is amongst young men, mainly 12 to 22 years of age. That was about 80% of the group, the males. And so that's certainly been a cause for concern. This slide, I apologize, it's a bit crowded, but it summarizes the vaccines that are really out there and in use right now here in the United States with Pfizer, Moderna, the J&J vaccine. AstraZeneca, as you know, is being used elsewhere, mainly in the UK, but also being manufactured by the Indian Serum Institute. And really the take-home messages are, this is sort of in terms of their dosing and generally their storage requirements, and the fact that by and large, the vaccine efficacy is very, very encouraging. And so the summary, at least from this part of the talk, is that in the US, the Food and Drug Administration have authorized, and the CDC recommends, Pfizer COVID vaccine for children and adolescents greater than or equal to 5 years based on vaccine efficacy or effectiveness. With only rare adverse effects, the risk of inflammatory syndrome following acute infection, the potential for long COVID, and indirect effects on mental health and education, the risk of severe disease in children with underlying medical conditions, and the desire to prevent COVID-19 of any severity in children remain compelling reasons for vaccination of children. In a review of the vaccine adverse event reporting system following administration of close to 9 million doses of the Pfizer vaccine to children aged 5 to 11 years, there were just 11 verified case reports of myocarditis in this group. Unfortunately, most cases were mild and short-lived. And there's the other aspect, and this was very elegantly summarized by Dr. Emma McBride. She's an infectious disease modeler at the Australian Institute of Tropical Health and Medicine. But she said, for every child's life you save, you may well save many, many more adult lives. For the most part, the benefits of the vaccine clearly outweigh the risks, independent, and this is an independent FDA review of Pfizer's data. There's also good news in terms of individuals who are moderately or severely immunocompromised. And there's a dosing schedule that came out actually the day before yesterday, Friday, from the American College of Immunization Practices and CDC, really saying that a booster dose should be given at least 3 months after the third dose for individuals who are immunocompromised with, say, chemotherapy, primary immunodeficiencies or immunodeficiencies that have been acquired. Well, that's great. There are still concerns, though, on vaccinating children. So Professor Gagandeep Kang, who's professor at Christian Medical College in Vellore, and also a fellow of the Royal Society, commented on an India forum, "We need more information on the safety, immunogenicity, and effectiveness of vaccines among children to be able to formulate a proper evidence-based policy. And we do not as yet know enough about the Omicron variant to change considerations of risk and benefit." That was on December the 3rd. Immunogenicity data from children given the ZyCoV-D vaccine, which is being given in India also in addition to the AstraZeneca vaccine, are not yet available, but data, at least in adults after 3 doses, shows that the adults made antibodies. Concerns from the UK Joint Committee on Vaccination and Immunization have shown that 1 million first doses of vaccine would prevent 15 cases of MIS-C, 87 hospitalizations, and 2 pediatric intensive care unit admissions. And so based on these data, the JCVI have continued to recommend vaccination of 16 to 17-year-olds, yes, and a list of children with comorbidities for which younger children should be vaccinated, but not, repeat, not routine vaccination of younger children. The rough picture in India in terms of COVID in children is that more than 50% of children 6 to 17 years have been infected. This is from the Indian Council of Medical Research as of July 2021. Antibodies were found in close to 60% of 16 to 69-year-olds and 61% of 10 to 17-year-olds, suggesting that more than 280 million children, Indian children, have been infected. However, there's limited data on how many develop severe acute disease or inflammatory syndrome. There are also anecdotal reports that children who were hospitalized, especially during the Delta pandemic there, mainly had comorbidities, but there have also been healthy children who have developed severe disease and died. India's been using the adenovirus vector vaccine, or the Oxford or AstraZeneca vaccine, and there's also been some reports of thrombosis with low platelets in some recipients. But it's unclear that there is an urgency for vaccine introduction. This is from Professor Gagandeep Kang. Beyond those who have comorbidities, there is, however, an urgent need to consider whether we should be considering the use of 1 or 2 doses of mRNA vaccine. And this is again quoting Professor Kang. So the lessons learned in the final few slides are that SARS-CoV-2 illustrates how a bug, a pathogen, can emerge and evolve to rapidly cause disease, illness, and death worldwide. In addition to impacting child health directly, the pandemic has had significant negative and long-lasting impacts on child education and development, mental health, and socioeconomic vulnerability. Understanding the pathophysiology of the acute and chronic consequences of SARS-CoV-2 infection is yielding important insights into host pathogen interaction that can improve diagnostic therapy and therapeutic approaches. Public-private pharmaceutical partnerships can deliver effective treatments and prevention approaches in a short time frame. And these strategies can be and should be used for future pandemics to optimize collaboration between public health and policy, epidemiology, infection control, basic science, and frontline healthcare workers to essentially improve and promote public health equity. On a personal level, this has impacted me with loss of relatives back home in India. And also one of my professors who trained me in infectious diseases, Dr. Raj Kapila, who was a heavyweight in the world of ID, set up really the unit in Newark, New Jersey at what is now Rutgers, but used to be UMDNJ at the medical school there. Dr. Kapila actually in the middle of the Delta epidemic went back to Delhi to help out relatives. And although I think he was vaccinated, he wound up succumbing to the effects of COVID over there. And of course, this morning, waking up to the news on hearing about India's Nightingale and the impact she had on the entire Indian population for over 70, 75 years with the music that she gave us, and the impact of COVID and how she also died. Thank you.
Thank you very much, Dr. Chakraborty, for an excellent presentation, and I so value the comprehensive presentation, and you shared some very important messages about the vaccine. We have time for a couple questions that I would like to ask you. The first one, which I think is on the mind of many of us, those who have young children, should my 5-year-old child receive a vaccine? My child is otherwise healthy, and what are your thoughts about providing that vaccine to them today?
I would advocate for it in terms of the vaccine efficacy or the effectiveness that, and some of the data that I presented. And at least from the data from these studies, we've really seen very few side effects that are potentially life-threatening, if any, in the 5 to 11-year-old group, at least from the study that was published in the New England Journal that I presented. So I would certainly say the benefits far, far outweigh the risks of vaccination, and I would therefore say go ahead and get your child vaccinated.
So another question that follows that I think is on the minds of many of us is that my child already had COVID-19, so why should I get the vaccine? How do you respond to that?
I think there was some nice antibody data from one of the science studies published a few months ago that compared individuals, and these were adults, albeit, but these were individuals and the antibodies they had from acquiring COVID, and they made comparisons with individuals who had COVID, but also got vaccinated. And the antibody levels were many, many fold higher. So I think they offer a greater level of protection than with just acquiring them from acquisition of infection alone.
And I think some of us are hearing this term, and you talked about long COVID. Does the vaccine actually help patients who already had long COVID infections and how they may recover in the long term?
Yeah, that's an excellent question. And it's one that I've been broached with for a number of different individuals. I would say that we don't have enough data just yet in terms of whether those who are getting these odd signs and symptoms after developing COVID, whether this is going to be worsened as a result of being immunized essentially with the spike protein. Having said that, one has to balance the risk of acquiring infection again. Let's say with the emergence, if you were infected with the original first strain, and you then have the Delta becomes epidemic or Omicron becomes epidemic, and if you acquire that virus again, so second or third dose of wild type infection, whether that's going to make your long COVID worse, or whether becoming immunized, that's a balancing act. But right now, I don't know the answer. Having said that, if this was my body and I had long COVID, I would probably get immunized. Great.
And I want to ask one more question, Dr. Chakraborty, and I do realize there were many others. We will bring you at the end. I have a few more for you, but one that's on the mind again, of many of us, and your expertise is so greatly appreciated. Do you have a prediction for the future of viral variants that are going to emerge that could become a pandemic again?
So I think, unfortunately, SARS-CoV-2, COVID, is here to stay. It will be here to stay in different populations and will circulate, and you may see epidemics occur from time to time. You really touch on a thing on an area of health and vaccine equity. And this is something I feel quite passionate about when it comes to global health. I'm actually delighted that given the numbers of Indians that have been immunized back in India, it's close on to 900 million, at least having one vaccine from a population of 1.4 billion. That's something to be proud of. However, there are countries like Democratic Republic of Congo, 110 million population, where just 0.1% of the population have received any form of vaccination. And those numbers are a little bit higher in, say, Nigeria, population of 220 million, or Ethiopia, just population above 100 million, where they're running at under 10% the vaccination. And so when you have these health disparities, my concern is that you allow the ability of the virus, let's just leave out the humanitarian aspect of this. You actually also allow the virus to develop more variants, and for these variants to come back and affect populations who have been immunized. So therefore there really has to be a global initiative, and that will take a lot of will between a lot of governments and a lot of individuals.
Dr. Chakraborty, thank you so much for making the time for us. And I also appreciate you staying till the end, where we will have a few more questions for you. And your expertise is so important to share with the community, and making the time for us today. Thank you.
Thank you. Thank you.
I'm going to now switch tracks to our next speaker. And it gives me pleasure to introduce Dr. Richa Sood. Dr. Sood is a consultant physician in internal medicine. She has been practicing in Rochester, Minnesota for almost 20 years. Dr. Sood trained in New Delhi first, where she completed her medical school and OB-GYN residency. After coming to the US, Dr. Sood completed an internal medicine residency training for women's health fellowship and obtained a master's degree in clinical research. She kept her emphasis on women's health, focusing on medical and hormonal issues of midlife women and beyond. In addition to seeing patients and publishing and speaking, she is also the mother of two beautiful girls, ages 17 and 11, and her husband is Dr. Amit Sood, who is also a physician. They are proud parents of their dog, Simba, who's now taught them to enjoy the snow. And so, Dr. Sood, I'm going to turn it over to you, because this topic was also very well perceived by our community as an important topic to bring to us. So thank you for presenting.
Sure, my pleasure. Thank you for having me. So I've been practicing menopause medicine for many years, as Dr. Pruthi alluded to, and almost practicing now what I've been preaching all along. That's kind of a disclaimer as I start. So the fun of getting old, right? All right, moving along. So we're going to talk about some myths and some facts around menopause. And as I've prepared this talk, I've learned a lot about the Indian menopause facts. So some of these are really new to me as well. So I'd love to share these with you. So I hope my slides move. Okay, so let's learn what to expect with menopause and the common treatment options as we talk about the myths and the facts. So what is menopause? I do not want to belabor anybody with definitions, but I'll be using these terms. So just a couple minutes on these. It's a Greek word. Meno is month, pauses is hot. So periods stop. When I see patients, I tell them this is not rocket science. When your periods stop for a whole year around 50, it is menopause, right? So naturally, it happens around the age of 51, 52 in the Western world. And in the Indian population, it's about 5 years sooner. Now, that's something to pause and think about. As we will go over later, this has implications. So that's rural as well as urban, not a whole lot of difference there. And when women have hysterectomy, they sometimes ask me, I'm in menopause now? The answer is no. It's the ovaries that really make the hormones. So if the ovaries are gone, then it's surgical menopause. Uterus going doesn't mean anything. The ovaries will do their thing and will age at the right time. Perimenopause is when the ovaries are stuttering. You know, the reserves that we are born with for all the eggs are being depleted. So in some months they do their job, in other months they basically don't do it. They're lazy. So the cycles can dance around, irregular cycles. So if someone has, say, no cycles for maybe 10 months and they get another cycle, it's still not menopause. You have to wait for a whole year. That's perimenopause. And if someone enters menopause too early, before 40, then we are asking a question of what could be a medical cause behind it. So we do some investigation, but not after 40. So essentially, people move from the reproductive phase to the perimenopausal phase to menopause. So I'm going to talk just a little bit about perimenopause. So the myth is, I don't need contraception when I'm going through perimenopause or change because I'm done making babies. Well, that's the myth. The fact being, this is the second peak in which unintended pregnancies happen. So people can get pregnant during perimenopause. So my message is contraception is something to be thought about at this phase of life. And I picked up this article from Menopause Journal, Risks of Being Sexual in Midlife. What we don't know can still hurt us, right? So we want to be mindful of that. And I just put a CDC reference here for people who are interested in checking it out, because they give a lot of information about the different options for contraception, as well as the risks associated and what could be safe for a particular person based on their medical history. So I'd invite you to check that out if that applies to you. Now, the next myth we are going to talk about is symptoms. So, we call these vasomotor symptoms, hot flashes, night sweats. And the notion goes, and I've heard it from my family and friends, it's not in India, it's just those Western women. We have a hot country, we are anyway hot. But that's not true. As I was looking up the data, 70% or so Indian women report hot flashes and night sweats. It's just that they have other symptoms as well. Many, many women will say, I'm tired. I just have body aches, my joints hurt, or, the GI symptoms. I think a lot of us have IBS, but it's kind of more prominent in the menopausal population. So those symptoms can overshadow the hot flashes and night sweats type symptoms. The other myth is that, if they come, they'll just go away in 6 months, maybe a year, maybe 2. No, the fact goes they could last about a decade. So 7 years is the median across all populations. It's a long-term deal for those who have to go through it. So the next myth is, if I treat hot flashes and night sweats, well, basically, I'm just going to push it out. Once I stop my treatment, everything is going to come right back. The fact is that we are programmed. Let's think of us as having this genetic programming, which decides, am I going to get hot flashes? How long are they going to go on for? And when does it reset? And it would reset at the same time. Now, the deal is many of us, when we are in our 50s, are at the peak of everything we are doing. We are, doing so much at work, at home, multiple responsibilities. And if we are not able to sleep well, constantly flushing and so on, we don't perform as well. So the idea is to improve our quality of life with the appropriate treatments during this phase, so we can do what we need to do. And when we stop the treatments, we will probably be done by then, because the system does reset over time. All right. So the next myth versus fact, hormone therapy, menopausal hormone therapy is dangerous. And I'm sure if I were to have people raise their hands, everybody will be raising both hands, that I've heard this from all my family and friends, and this is not a good deal. Sandhya must be smiling there. We talk about these things in our practices. She does breast medicine, I do hormone medicine. We overlap, and there's some tug of war. Right? So hormone therapy is one of the most effective treatments at menopause, and we would all agree on that. So the deal is, this is a sweet spot. The right person at the right time and hormones at the right dose are very, very safe. So I like to show this slide. This is something I pulled from, when first time Premarin, which is the hormone that has been in the US market since 1940s, came out. And I just put it in red. The physician who puts a woman on Premarin when she's suffering from menopause usually makes her more pleasant to live with once again. And we would all be like, really? But this was very popular ad, and Premarin ruled the market. So until 1970s, hormones were the best thing that happened to women. And even subsequently, they were good. They had more indications, bones came into the picture, and there was a lot of excitement that they are also going to prevent heart problems for women as the observational data got accumulated. So why the confusion? Why do we worry about hormones? Well, the story goes that these observational studies had to be confirmed through high quality studies, which are called randomized studies. So this big randomized study, Women's Health Initiative, was done. And it was a multi-center study, had 27,000 women, and they spent about $1 billion with a B. So it's a very, very big study. And the idea was not to see if hormones helped hot flashes. We had known that for decades. The idea was to see if hormones could really prevent heart attacks and make women live longer. So they wanted women to be older, because if you enroll somebody in their 40s, you don't have the time or money or resources to do a study for 30 years. So most women were older, in their 60s, even up late 70s. And basically, they were wanting to see if heart attacks would happen or not. Well, guess what? Elderly women get heart attacks. So these women got heart attacks. So the study got pulled to the side of negative data, and the results were declared in a big haste, and lots of controversies happened around it. That's not a good chapter in the hormone history. But time is a healer. Over time, the pendulum has swung back to the middle, and now we have rehashed that data. So there are a few pearls that came out, not to belabor it a whole lot, but just drawing your attention that if hormone therapy is used in women who are between 50 to 60, so that's when menopause happens, right? Then if women were to do estrogen alone, there will be 12 fewer cases of heart attack, 8 fewer breast cancers. And that's something we don't talk about a whole lot. This is estrogen alone. Now, the study also had an arm with progestin, which was synthetic, and there was some concern about breast cancer in that group. Most of us in our practices have moved to a more natural progesterone, so we are less concerned, although that data is observational. But overall, in young women, less heart attacks, less breast cancers, and who can fight with this? Less overall mortality. Well, that's what we are all striving for, right? Live longer, live healthier. So the data was very convincing, although people argued that this was, not the main outcome. It was subset. Yes. All those are good things. But what are we trying to tell women here? If you do hormone therapy, you'll be just fine and maybe even good. That's the message. Fewer fractures, fewer colorectal cancers. And all these concerns we talk about are in a very rare category. So when I counsel patients in my practice, I tell them, if you're symptomatic and it's affecting your quality of life, I don't give too many guarantees. But if you have a normal mammogram and if you were to do hormones for maybe a year, 2 years, you'll be just fine. Don't worry. And we can do it for longer for sure. But beyond that, I don't give guarantees as such. So next myth. If I take hormone therapy, I will get breast cancer. And, we all have seen patients who said, I started hormones 3 months ago and here's my mammogram abnormal. Doesn't work like that. It takes years and years before you can attribute any cancer to hormones. So for a short duration, that's not the truth. And here's something I pulled from Indian Menopause Society consensus statement. And basically, they're trying to say that the risk of hormones is so low that if somebody was eating too much and getting bigger, their risk would be more because of that. If they were drinking a lot of alcohol, the risk might be because of that. So actually, lifestyle modification will help us reduce the risk, and using hormones for the short term will not increase the risk. That's kind of the summary of it. And what's more, another thing that I love to talk about is hormones come almost as a package deal. So if I have a patient tell me she's having hot flashes, etc., if I dig deeper, there's a very good chance she'll say, I'm a little moody. My husband tells me that. I'm irritable, and he's my target. Most women are like that. And then they will also say, my joints are just achy. It's not red. It's not painful. It's just achy. It's not arthritic, just achy. And then I don't sleep as well. So many different things are happening. So interestingly, if all this is happening in the context of perimenopause and menopause, hormones are likely to fix all of that. Although FDA says don't use it for those indications primarily. You can use it for hot flashes, but it's a package deal. So a lot of benefits will follow. And Dr. Kumar is one of the hosts here, and hopefully she'll agree with me. The metabolic side of hormones, diabetics or non-diabetics, it helps with insulin sensitization. That's a huge thing because Indian population, 1 in 4 are having metabolic syndrome now. So we really want to be mindful of lifestyle, but if hormones were being used, they'd be helpful, not harmful. Moving along. Some of you may have looked into this or may have had patients like compounded hormones. I go to the pharmacist and he checks my saliva and he makes something that's customized to me. I like that idea. Well, it's very convincing on the face value with almost no science backing it. So if I were to counsel my patients, I would say, take what is FDA approved because it has been, it is standardized. It goes through purity checks. It is from one batch to the next, you get the same stuff. And there's regulation. Somebody is looking at what they are doing, not so for compounding pharmacies. So if you are a hormone believer, go for the FDA approved versions. And then this is something I ask my patients. So majority of women who I see in my practice will tell me I have hot flashes, but they don't volunteer as easily if they have problems with dryness, vaginal dryness. And if you ask, a large proportion will be, yes, I have a problem. So the message that what I've learned is always ask. And that's why I bring it to the table here for discussion that yes, vaginal dryness is very common. And this discomfort is a part of menopause, not getting old per se, but having loss of estrogen. And the farther we go out from menopause, the more the tissues dry up. And some people have so much discomfort that their sex life gets affected very badly. So how do we fix this problem? Very easily treatable. Vaginal estrogen. So far I've talked about whole body estrogen, which we call systemic, but vagina is open to the outside world. It doesn't need indirect supply of estrogen through the blood. It can be put directly in the vagina. So we call it local estrogen. And local estrogen, the myth is it's risky again because the package insert says the same stuff. The real deal is vaginal estrogen, when used in a small dose correctly, is not absorbed. So it's not risky to any level compared to other hormones, which I anyway said not risky. So you can see how low risk we are talking about here. So vaginal estrogen does not increase the risk of breast cancer or heart disease or clotting or uterine cancer. And the other good news is with systemic hormones, we have sort of a timeline. After maybe 60, 65, we have a conversation, let's think of stopping because, overall aging related risks are going up. Doesn't apply to vaginal estrogen, again, because it's local. So if a person has no hormone dependent cancer, they can just use vaginal estrogen for long, for even, in their 80s. The one thing that many urologists have been doing nowadays is many 80-year-olds get recurrent urine infections. Part of it is because their tissues are so thin and they have this, bugs keep going in and they are prone to that. So in addition to other treatments, they are also given this local estrogen to buff up the tissues of the urethral opening. So that can be safely used in 80-some-year-olds. And so most of my patients find that information helpful as they are making their decisions. This slide is only for reference, that these are the products that are available for vaginal estrogen use and the doses. So if somebody needs that, they can definitely, I'm happy to share. All right, this is where it gets tricky. Weight gain at menopause. Almost like, that's the third biggest problem, I would say. Everybody's experiencing to some level, and the debate keeps going on. Is it menopause? Is it aging? The deal is, although weight gain is seen with majority of women, what is more associated with estrogen decline is change in body composition, which means women, we start off as pears, kind of turn into apples, central fat. And this central fat is not just cosmetically a problem, it's also oxidative. So it connects to the cardiovascular risk down the road. And also we lose muscle mass as estrogen goes down. So those are the real problems associated with estrogen decline. And the last fact I want to talk about is we associate menopause to old age. And I take you back to my second slide, where I said an average Indian woman enters menopause at 46 point some years. I think that's not old age. We're very young when menopause happens. And isn't 60 the new 40, right? We're all aging much better. So we have to take charge. I sometimes think about it this way, that nature probably doesn't have a plan for us humans. We were in the jungles. We were living up to 30, 40, maybe 50, and then we were gone. And here we are with all the public health measures and, our antibiotics and vaccines and whatnot. We are starting to live up to 70 or 80. And nature says, like, this is new. It'll take millions of years to do something to us. So we want to take charge, add life back to the years we have added and say, how do we age younger? And that's part of the next couple of slides that I want to go over. One thing that I learned is breast cancer in India peaks before 50. I was shocked. In the Western world, it peaks in the 70s, perhaps 80. Those are the two graphs there to compare that. So this is not something that has happened always. In the last 20 or 30 years, the peak of breast cancer has moved to a younger population, which is scary. And many people don't think of preventative medicine as much. There are many other struggles, we get it, but sometimes people have resources and still that's not at the forefront. So screening for breast cancer is a big, big part of self-care when it comes to living longer and healthier. And then, according to the Indian Menopause Society, now there are other big issues related to earlier menopause. So osteoporosis. One figure that caught my attention, 40% of women at age 40 have lost significant bone mass. And by 65, 80 to 85% women will be in the bone thinning, osteopenia, osteoporosis range. It's pretty scary. And we start off at a disadvantage. Asian people have a smaller frame. And then there's probably nutritional issues and such. So that's something to watch for and proactively treat, because fractures are a big part of mortality and morbidity as we get older. And then we've talked about the type 2 diabetes. It presents earlier. It's our genes, our metabolism, the explosion of metabolic syndrome in our country. And that kind of ties into cardiovascular outcomes. Myocardial infarction occurs in younger Indian women compared to the Western population. So I think the core message is that we have this call to action. So as we start transitioning, the perimenopause is almost the time to start to tune in to the symptoms that need improvement for quality of life. Then we're talking about lifestyle modifications with diet and exercise, so we can reduce the cardiovascular morbidity and mortality. And we screen for diabetes, hypertension, lipids, and so on. We get cancer screenings for cervical cancer, breast cancer, colon cancer, and we get age-appropriate vaccinations. That's what it boils down to for us to live a healthy life. And the life expectancy of Indian women is about 70, Western world is 82-ish, and they are hoping that this will go to 77 in the next 20, 30 years for India. And that again is like, we want to be productive and living a meaning-driven life, and for that we need good health, right? So taking charge. So this is my summary here. Indian women enter menopause sooner. Their symptom experience is similar for vasomotor symptoms and vaginal dryness, plus there's more musculoskeletal complaints and fatigue. What is really concerning is that earlier bone thinning, more prevalent, more earlier breast cancers, and so on. And the symptoms of transition are treatable. Hormones are not our enemies. They are friends when used for the right person at the right age, with the right dose, with the right hormones. And menopause is a good time to refocus on self. Women are givers by design, and we give and give more. But my core message is, it's good to give, but it's good to give yourself so you can give back to the system. And that's all I have. Thank you so much for your time.
Thank you so much, Dr. Sood, for such a wonderful presentation and just beautifully delivered. Can't thank you enough for doing that. We do have a few questions for you. The first one is, if sleep issues are occurring around menopause, are there options to treat sleep? And do you know if there's a benefit from using such these hormone therapy options to help with sleep? I know Dr. Kolla will be speaking next, so I'd love to hear his perspective. But what are your thoughts about using hormones to help me sleep better?
Okay, so I'm not a sleep specialist. With that caveat, I'll just add first that sleep gets disrupted at menopause because of multiple reasons, one of them being the night sweats. So if we use hormones, we fix the night sweats, which can fix the sleep. The second thing is that sleep architecture seems to get disturbed. A lot of women have lighter sleep. And when we use hormone therapy, many women who still have their uterus have to use a medication called progesterone, which protects the uterus. Now, the good news is, and people love it, progesterone helps with sleep. So that's sort of fixing that architecture issue. When women are going through the change, sometimes the weight gain can become a problem because then they can be predisposed to what we call obstructive sleep apnea. And they might be snoring, getting a headache in the morning, just tired. So we want to exclude that and look for that and treat that for itself. That's not hormonally treated. And the big picture is many women have this very busy, active, racing mind. And it's almost like, as long as we are alive, our heart has to beat and our mind has to think. And it starts thinking too much. And that kind of makes us loop. So I think there's a lot of role for a CBT, cognitive behavioral therapy. And in this tele world, there is ICBT, tele CBT, there's lots of options. So the summary answer is that hormones can fix the part of the sleep disruption related to night sweats or architecture, but there are many other reasons that can disrupt sleep. So we want to be looking bigger and fixing the piece of the puzzle that's missing rather than the wrong piece.
Great, thank you. Here's another question. How long do you decide to keep someone on estrogen after menopause? Do you stop after a few years and reassess, or is this something they take the rest of their life?
Oh, no, they don't take it rest of their life. That's clear. And when we start the treatment, we tend to bring people back first within 3 months to make sure it's agreeing with them, the dose is right, no side effects, and so on. Once they are okay with that, then we bring them in every year, and they need to see their provider every year. I do 3 things. I make sure that they still have symptoms. So I'll ask them, is there any breakthrough symptom? Did you forget to fill your medication? Were you traveling or something? Those kind of questions to get a sense if their symptoms are still there. Most people will have symptoms for the first 3 to 5 years. So, the answer is yes. The second question is it still safe? Which means asking, has there been any change in your medical history? Any new cardiovascular symptoms, neurologic symptoms, clotting? Is your mammogram normal? Any new family history? If that is all okay, the third question is the dose. And generally, we don't change the dose within the first couple, 3 years. So those 3 things answered, people can continue hormone therapy. As I mentioned, between ages 50 to 60, it is super safe. And a lot of women will have symptoms for 5 to 7 years. So majority will be thinking of stopping their hormones maybe after 5, 6, 7 years of hormones, although some people get scared and they would stop sooner. But as a physician, I'm not very concerned in the first few years.
Great, thank you. Here's a really good question, and you commented on this during your talk about some of the lifestyle factors, but when you showed the risk of breast cancer as a trend in India, is this true also for Indian women living in the United States, that same trend, or is it somewhat different because of some of the lifestyle factors?
Yeah. I was scared that question will come, but I knew Dr. Pruthi is here. So, so here is what I know, and probably I'll seek your input. There was a mention of UK-based Indians. And when they looked at the trend, after 1 or 2 generations, people start kind of going to the trend of the country they live in. So the diet, the exposure, all that increases their risk accordingly. So I would say it's the people in US probably will have Indian risk, maybe in the middle, maybe not the 50, maybe not the 70, somewhere in between, but I don't have data to support that.
No, but you did comment, and I do appreciate you mentioning the lifestyle and the diet. I think that the US consumption of the processed foods, the dietary fat, alcohol, there's a combination of factors that play into the breast cancer trends that we're seeing here, much like what we would see in the US. So it's important, again, to talk about the importance of modification of these lifestyle factors. But thank you for bringing that up. So I'm going to now thank you, Dr. Sood, for the excellent presentation and just awesome information you shared with all of us. So we would like you to stay till the end because we do have a few other questions. Thanks again.
Thank you.
I'm now going to move on to our third presenter, and I'm privileged to have with us today Dr. Bhanuprakash Kolla. Dr. Kolla is originally from Hyderabad, India. He completed his medical training from Osmania Medical College in Hyderabad. He then completed a residency and fellowship at Oxford in England and did an additional psychiatry residency and sleep medicine and addiction psychiatry fellowship in the United States. Dr. Kolla is practicing both sleep medicine and addiction psychiatry. He lives in Rochester with his wife, who is also a physician, and has an 8- and 6-year-old daughters. Thank you, Dr. Kolla. I'm going to now turn it over to you. Can you put your mute off, Banu? Thank you.
Okay, yeah, it wasn't letting me earlier. I think I'll make less sense unmuted, but okay. And I think Dr. Sood needs to stop sharing for me to
Yeah,
be
I
able to
noticed that.
share.
That's what I'm noticing as well. Thank you, Dr.
Okay.
Sood.
Yeah, and yes, Dr. Sood actually covered the sleep question much better than I did. I usually tell my patients, like I tell my wife, sleep is overrated, get over it. Okay, so I'm going to be talking about depression. I have tried to make this more relevant to the South Asian and more specifically the Indian community. And this is a little bit of a nebulous topic because in psychiatry, we are sometimes dealing with nebulous issues. What I'm trying to do here is to try and get you to understand this whole concept of what is major depression, recognize the symptoms of major depression, and then we will talk a little bit about the risk factors, the prevalence, and look at that, especially in the South Asian context. I have tried to include some studies. Unfortunately, these are mostly India specific. I didn't find good data to use from other countries in the South Asian region. Tried to see what is available from the immigrant population in the US, and again, not too much. Then we'll talk a little bit about common treatment options and end with a Q&A. So this comes up very often for us. So isn't depression just sadness? Sadness is a emotion. It's a natural emotion. And without sadness, there really is no life. None of the other emotions make sense unless people can experience sadness too. Major depression is completely different. It's a biologically based brain disease. So it is a pathology. It's a pathological condition, which is pretty much a brain disease. So just like diabetes is a disease of the pancreas, we think of depression as a disease of the brain. How it differs from sadness is in that when we have emotions, it is sort of in the context of something that is happening in our life. It is proportional to the kind of distress we are experiencing, and it lasts for a little while, and then we move on. Depression is different. So when we are assessing the sadness, there is a difference in the intensity. So it's much more intense. So if you rate it as a 1 out of 10, it's 10 out of 10. The duration, it lasts much longer than you would expect it to. The quality of the experience is very different. So sadness, you still can find some periods of joy, some enjoyment, you move on. But in depression, there is this feature, what's called anhedonia, which technically means you're not getting pleasure out of anything. And that, again, is a very distinct quality to depression. There's also a difference in the expression of the emotion and the appropriateness. With all that said, it still can be extremely difficult in clinical practice to tease these apart. And especially in the context of bereavement, so after the death of a close one, sadness, bereavement, depression, it becomes much more of a complicated picture. So we think in psychiatry of syndromes, and major depressive disorder is a syndromic illness. The main features, you have to have one of these two, so the sadness or anhedonia, but the rest of the symptoms we sort of remember with this mnemonic SIGI cap. So you have the S, which is the sadness or the sad mood, but you also have sleep disruption. A lot of people, about 80 to 90%, will have insomnia, but the flip, hypersomnia or feeling excessively sleepy, is also possible, and about 10% of people who are depressed actually complain of feeling excessively sleepy. We talked about the anhedonia, which is a necessary criterion. Then there is this worthlessness, excessive or inappropriate guilt, which is people feel that they have wronged somebody, that they are not worth something, and it's very difficult for them to shake that. There is also fatigue, loss of energy. There is a diminished ability to think or concentrate. There is a change in appetite. Again, it's a 80, 90 to 10% rule where the majority have a loss of appetite and weight loss, but about 10% can actually present with an increased appetite and weight gain too. Most people again present with what we call psychomotor retardation. So when you observe them, when you see them, what you're actually noticing is that there's little inflection in their tone, their expressions change, so they're not as expressive, they're not moving as much, really sitting around, not doing much. And this recurrent thoughts of death and suicidal thoughts are a core symptom of depression, particularly worrisome symptom, and in theory can make the depression lethal, not just in theory, in practice as well. So when we look at these symptoms, most of the symptoms that have been accumulated in this syndrome of depression have come from Western studies looking at symptom complexes in Western populations that have depression. There have been some studies looking at the symptom profile in the Indian context, and what they have found is it is more or less similar. So this depression is going to present very similarly in the Indian context as compared to the Western context too. Most studies have actually in the Indian context shown that there is this high prevalence of somatic symptoms. So there is this focus on physical functioning. And this I have observed quite often in my training and even in family members who have had depression, where it is this focus that something is not functioning or they have an illness that cannot be treated. Depressed mood, lack of interest, reduced functioning at work, they're present in all cases. Other common symptoms in the Indian context are again the sleep difficulties, but again, Dr. Sood talked about how everybody has IBS, so gastrointestinal symptoms, lack of self-confidence, disruption in social functioning. The one symptom that is less likely to be present in the South Asian context is this paranoia, or where they're thinking that people are trying to hurt them, harm them in some way, or depersonalization, where they feel like the world is not real. Again, in an epidemiological context, in the Western world, it is a psychiatric disease that has the highest lifetime prevalence of all of the specific psychiatric disorders, up to 20%. So 1 in 5 will experience major depression. And the large, well-done studies have shown a prevalence of roughly about 16%. It is highest in the 25 to 44-year-old age range, with a mean age of presentation of about 30. And it is the 4th highest cause of disability, so it really is a debilitating condition. There was a recent Lancet study which published epidemiological data from India in 2019, and you can see the top graph here is depression. So they looked at other conditions too, so anxiety disorders, idiopathic developmental disability, and conduct disorder. And very clearly, it is the southern states that seem to have a higher prevalence of depression and anxiety. The developmental intellectual disability, so this is more of the genetic syndromes, they're much more likely in the northern states, same with the conduct disorder. So in this study, they found a prevalence of about 3.3%, 2.7% in men and 3.9% in women. And we will talk a little bit about this gender discrepancy, sex discrepancy. It is consistently shown to be more common in women as compared to men. And there are many reasons for this. So it could be hormonal, it could be societal expectations, gender roles, all of those play a role. But this is consistent across all cultures that women have a higher rate as compared to men. Other studies actually have shown a higher prevalence, which is more in line with the Western prevalence of between 10 to 20%. But this large study showed the prevalence was about 3.3%. And the risk factors for depression were similar in the Indian context as compared to the Western context. So I had talked about some studies looking at immigrants, and these are studies from the United States where they looked at immigrant populations and saw what the risk factors were for depression in the immigrant population. So you can see here too, women were at a much higher risk. Those who were married, it was protective, so marriage was protective. The longer they lived in the US, the less likely they were to have, depression. And Asian and Pacific Islanders had a much lower risk as compared to the other ethnicities. They also here interestingly looked at the visa that they got, if it was family preference, employment, diversity, refugee, and the refugee population had a much higher rate than the other kind of visa categories. And this makes sense because, again, they looked at political violence. Those who were fleeing violence, they had a much higher rate of depression as compared to those who were not. With the other categories, it really made no difference. There have been some studies looking specifically. So the previous study was all immigrants. There have been some looking at South Asian immigrants. Most of them have come from a group operating out of Central California that have looked at Punjabi immigrant population. And what they showed there is the risk factors. When they looked at the risk factors for depression in this specific population, it was not being able to speak the language. The language preference had a risk. Again, gender had a risk. Those who had a negative religious coping strategy as compared to positive religious coping strategy. So they defined this as those who felt that the religion was helping as opposed to hindering their coping with stress. So those who had that difference, the negative religious coping increased the risk, and satisfaction with life reduced risk, anxiety increased risk. So that was in the Indian and immigrant populations. But in general, we've talked about how sex is a risk factor. Prior to puberty, the prevalence of depression is equal in boys and girls. And after that, it becomes about 2 times more common in females as compared to males. It starts at puberty, extends into adulthood. This persists through menopause as well. And this trend is seen across countries, across ethnic groups. The peak prevalence years appear to be same for men and women, and there is a higher comorbidity of anxiety disorders in women and alcohol use disorders in men. It does not seem to impact the rates of relapse, and we'll talk about how it's a chronic relapsing illness in a bit. So again, just showing that the highest prevalence is in the younger age group, and then the prevalence goes down. There is this difference in terms of how depression presents and how it behaves if it occurs in the younger age group as compared to 65 and older. So when it's occurring in adolescence or in childhood, it tends to be more severe, it tends to be more recurrent, it tends to be associated with more of a lifetime suicide attempt, and overall illness burden is greater. In those 65 and older, there is much more of a female predominance. There's it's associated with low socioeconomic status, associated with bereavement, prior history of depression, cognitive decline, and medical comorbidity seem to be risks for this over 65 depression. There is a strong genetic component. So we look at what's called heritability. Heritability is a concept where you can tell how much of a disease is genetically driven. So how much are genes explaining this disease? And for depression, it's about 60%. So there are different ways to look at it, in that 60% of it is genetically driven, but also there is a 40% environmental component. If there is a first-degree relative who has major depression, it's about 2 to 3 times increasing your risk of developing depression. In monozygotic twins, so if they have the complete same DNA, it's about a 50% concordance, so you're 50% likely to have it. If you have a sibling or a dizygotic twin, you have a 20% prevalence. And this has been borne out with multiple adoption studies where they have had depressed patients with biologically depressed, so you have a adoptee, the biological parents have depression, they have been adopted into a family which does not have depression, their risk will be very similar to their genetic family. So again, genetically driven. But there are these environmental factors too. The most important is this prolonged exposure to severe trauma, especially in childhood and adolescence, and that is linked to a much higher risk of developing a depressive disorder. These traumas, parental loss during these critical developmental periods, they cause these permanent alterations in the stress system, immune and inflammatory markers, and that sort of sets them up for a higher risk for major depression. Going through life too, stressful events, so losses, death of a loved one, divorce, unemployment, retirement even, all of those are environmental factors that can be associated with major depression. Switching gears a little, talking about etiology, the honest answer is that we don't completely understand what causes major depression. There is no single unifying pathophysiology that has yet to be discovered. We have some strands. We know that there is some change in neurotransmitter function. So there is this neurotransmitter dysfunction. A majority of the drugs that we use to treat depression act on neurotransmitters. They work. So we assume that there is some change in neurotransmitter function. There are also studies showing there is a neuroendocrine dysfunction. There's a maladaptive stress response. So people respond poorly to stress. There is a change in the HPA axis, cortisol. Neurotrophin, neuroplasticity changes, neuroimmune mechanisms change, and we also talked about genetics. So many different ways that can lead to this syndrome. In about 14% of cases, it is a single episode. So what that means is in 85% of cases, there will be a recurrence. In about 12%, it's chronic unremitting, in that once you have it, you actually have the depression, it doesn't go away. In the 85% that it is recurrent, you have a complete recovery, and then you have a second episode. And the median is about 4 episodes per lifetime. So if you have one episode, 85% chance that you'll have another, and on average about 4 in the entire lifespan. And on average, they last about 20 weeks. The severity of the symptoms can vary from person to person, episode to episode, and even within a single episode, you can see some fluctuation. We talked about how this suicide, which is a core symptom of major depression, can be lethal. The most common risk factor for a suicide attempt and completed suicide is a major depressive disorder diagnosis. So those who have major depression, about 21% will attempt suicide. So again, 1 in 5 with depression have attempted suicide, and the lifetime risk of suicide and death secondary to the suicide is about 2 to 9%. So fairly high. Persons with depression are 20 times more likely to die by suicide than the general population. So this again is a substantial increased risk. And this is where in psychiatry, we are spending a lot of time assessing risk, trying to mitigate this risk. The risk is highest in men, so males. Those who have a prior suicide attempt, they have a higher risk of attempting again and completing it. So nothing predicts behavior like past behavior. The more severe the depression, the higher the likelihood. Hopelessness, so this is a core symptom that you're looking for. So if they see no light at the end of the tunnel, nothing is going to get better. That again is a high risk. If there is this comorbidity with substance use disorders, so alcohol, other drugs, anxiety, personality disorders, all of those increase the risk. So just wanted to go off on a very slight tangent. This is related. So there was this very high profile suicide, Sushant Singh Rajput, and very clearly had depression, was seeing a psychiatrist, was on antidepressants. There was a previous attempt, there was social isolation, there was some stress. And this I saw as a clear lost opportunity where very quickly it devolved into sensationalism and a lot of other sideshows rather than concentrating on recognizing this very common illness, recognizing the risk associated with it and the need for treatment. And this has unfortunately happened with a few other high-profile suicides too. So with depression, trying to ensure that people understand that it's a biologically based illness associated with this risk, and this is something that needs to be taken seriously and understood in that context. So what are the treatments? The common ones are medications. We'll talk a little bit about those. There are talk therapies. There are other treatments too. But a question that comes up is, can we prevent it? The most important preventative strategy is actually what's at the bottom. So reducing this childhood adversity abuse. So we talked about how trauma is a major risk factor for going on to developing depression. So trying to mitigate that trauma, reducing that, and intervening quickly, that is the most important prevention strategy. But at an individual level, it is getting adequate exercise. There are multiple studies. This is a meta-analysis showing that exercise is actually preventative. And roughly the guide is about 30 to 45 minutes, at least 5 times a week, moderately vigorous aerobic exercise. Again, as a sleep disorder specialist, as a sleep specialist, we pay attention to insomnia too. Insomnia can precede depression. So those who are sleeping poorly have higher risk. So treating the insomnia to reduce the risk, moderating alcohol use, pro-social activities. There are many studies which show that people who have some meaning or purpose, whatever that is, so whether that is religious, whether that is friends that they're meeting with, other kind of activities in society where they feel themselves connected, that can be preventative, and preventing and treating all chronic medical illnesses too. In terms of medications, there are many different classes of antidepressants. No one is any better than the other. All are similarly effective. About 30 to 50% respond. About 30 to 40% will completely remit. So they are effective. All of them have very different side effect profiles. So usually the choice is based on trial and error, and you're looking at what side effects you want and what you absolutely want to avoid when you're making this decision. Usually, once you start somebody on the medication, you want to keep them on it for about 9 to 12 months, usually 6 months after they have completely recovered. If people have recurrent episodes, you're looking at lifetime treatment with antidepressants. Decisions regarding the discontinuation usually depends on the severity and the recurrence risk. So you want to, again, weigh, like with everything, risks and benefits. And if there are really very few risks with staying on the medicine, you really want to keep them on it for life. And all of these, as with everything in medicine, is based on shared decision making. And of course, we talked about the side effect profile. This is again something we run into quite commonly in the South Asian and again Indian context. So there is this large Lancet. So this is a headline from a newspaper. Large Lancet study finds antidepressants do work in the Indian context. Indian docs say problem is attitude. There have been some studies which have looked at adherence in the Indian context, and about less than half the patients who received an antidepressant prescription adhered to their medication at 1 month, and less than 1/3 at 90 days, which is the minimum recommended duration of the antidepressant treatment. So adherence is an issue. Partly could be explained by the side effect profiles, and my Indian patients are particularly sensitive to side effects, and there could be a genetic component to it, but also it could be cultural in terms of the attention they pay to the side effects caused by the antidepressants. This study, which looked at 100 patients, found that about 64% reported flatulence, a lot of them, about 60% somnolence, memory impairment, decreased concentration, yawning, fatigue. So a very high proportion are experiencing side effects. We don't know if that's driving the adherence issue though. There are many forms of talk therapies, and again, like with antidepressants, no one form is any better than the other. All of them have been shown to be efficacious. The most common ones are cognitive behavior therapy. So cognitive behavior therapy is based on this triangle where we think that thoughts, behaviors, and emotions are interconnected. So if we can target behaviors, that will help improve emotions and thoughts. So other forms are interpersonal therapy, supportive psychotherapy, psychodynamic psychotherapy. I apologize. I think my 6-year-old wants to listen to my talk too. The other non-pharmacological treatments we said were exercise. So again, moderate aerobic exercise 3 to 5 times per week, 45 to 60 minutes per session. Behavioral activation, which is actually scheduling activity and being active rather than sitting and not doing much through the day. Use of light boxes, especially in the context of seasonal affective disorder, again, very common in northern climates like Minnesota, where the light changes. This is a very specific form of depression, which tends to get worse when clocks change in November, tends to improve in the springtime. So there again, light boxes have been shown to be particularly effective. So just to summarize, depression is common. It's much more than sadness. It's a biologically based illness. It's highly prevalent in the general population. It's common in the South Asian and immigrant populations as well. Diagnosis is based on clinical assessment. Generally, we don't need any tests. We want to rule out some common conditions like hypothyroidism, a few other medical conditions that can mimic this, but almost always they will have symptoms of those other medical conditions. It is associated with this high risk of suicide. There are some measures that people can take to reduce the risk. So we talked about exercise, being pro-social, treating insomnia, moderating alcohol use, and there are multiple treatment options available. They are effective. Adherence is really where we want to concentrate. So with that, I'll stop, take questions, and thank you.
Thank you so much, Dr. Kolla, for the comprehensive overview of a very important topic that we really wanted to share with the community at large. And your comments, your perspective on it was really important. And one question that I think is on the minds of many of us is, how do we get away from depression being what is termed a silent illness, and especially in our culture where we tend to not want to talk about symptoms? Your thoughts on that? And I think this ties into another question as to how do you actually get a family member to get help because of this phobia around, I don't want to be labeled as having depression.
Right. I think the most important thing here is sunlight. It is making sure that people talk about it. The more we normalize it, the more people acknowledge their and their family members' illnesses and make it something that is easy to talk about. I think the better it'll get for the community over time. And I think the culture also plays a significant role. So the way it gets portrayed in the culture, I think, is important. In terms of how you get your family member to seek help, that is difficult. And what you're trying to do there is to leverage your relationship with them and their relationship with healthcare providers. So it is, if there is a physician that they see, if it's a primary care provider, if it is their endocrinologist, their breast specialist, there is that connection, making sure that they speak to them, that this gets brought up, and the physician, the healthcare provider then normalizes it, steers them in the direction of seeking treatment and adhering to the treatment. I think that's what's going to give us our best shot at getting them connected with the kind of resources and help that they need.
Thank you so much for those comments. And you're right, it's that relationship they have with a provider they can trust. And that is important, that we can do more with our family members. I think this brings, and I'm glad that Dr. Chakraborty and Dr. Sood are back on as our panel. And you as well, Dr. Kolla, the impact the pandemic has had, we don't talk about it on having a COVID infection or isolation as a result of the pandemic on mental health. And of course, children, how they're affected by this. So many perspectives of what this pandemic has done. What can we do? And how can we change that so we can make people have a positive outlook, which is so important?
I don't know if Dr. Kolla wants to answer that first, and I'll be happy to put my input.
Thank you. We would love to hear all three of your perspectives. Dr. Kolla, you get to go first.
So as a father of a 6 and a 8-year-old, I have seen how the pandemic impacts them and the parents too. And I think what Dr. Chakraborty had talked about, I think is particularly illuminating here, in that we have to at some point learn to live with this. I think there is a balance to be struck between safety. We know, so vaccines don't work, vaccinations programs work. So making sure that vaccinations happen, balancing risks, but also recognizing that this repeated isolation, shutdown, all of that takes its toll. So taking that into account. And if it is inevitable, all of us are I hope scientifically driven. So make careful, considered choices. If it is inevitable, then try and figure out how best we can mitigate some of those risks too. So how can we stay connected when we need to be under shutdown, lockdown, but also being very mindful that we want to keep it really short. We want to be attentive to loss of all of those social interactions, education that can also happen with all of this. I don't know if Dr. Chakraborty, Dr. Sood feel differently.
Go ahead. That's well said, Dr. Kolla. Dr. Chakraborty, what are your thoughts on this? This is a tough time for many.
Yeah. Well, I'm going to move along the age spectrum from Dr. Kolla. As a father of a very dynamic and active and extrovert 18-year-old and a more introvert 22-year-old, both of whom had their education disrupted, one from college, having to spend significant amounts of time at home, and the other one from high school. I think one of the key things that, and this is only anecdotal, but it's maybe also some reports as well, what I found helped was the family unit, the access to relatives, particularly grandparents in our case, a grandparent in our case, and the ability, even if it is virtually, to connect with other individuals in our case in the UK. I think some of that can help, but I realize that the outlook can be a bit more challenging for children being brought up in homes where you don't have that extensive support with relatives and with caregivers. And I think that's where certainly issues have arisen when it comes to childcare, the issues around attending school, having access to laptop, having access to Wi-Fi, and all those things which we, as perhaps a middle class group, would take for granted and think, well, that's obvious. That's an obvious situation. That's not always the case here in the United States. And so, what are you going to offer if school is closed and you don't have access to the resources? Something that you take for granted, like Wi-Fi, and a parent or family being able to afford Wi-Fi. I think these things have to be addressed more at a community-based level and have to be recognized early on. And sometimes it's very difficult to plan for that when you have a pandemic that is moving literally from day to day.
I really appreciate your perspective on the disruption it had for older children as well. And thank you for sharing that. And I think I'd love to hear Dr. Sood's comments as well, because she sees the impact on the pandemic on women, family caregivers who carry a lot of that stress, not only as parents, but working work-life balance. What are your thoughts, Dr. Sood?
So many women I see are in that classic sandwich generation. They're taking care of both sides. And with elderly parents, initially in the pandemic, there was a lot of fear and concern as the disease was sort of unleashing and we didn't know where we were going. Over time, a lot of people sort of took charge. It's almost like, identifying a stressor, which we all faced with the disease, the isolation, the unknown, and then doing what we can about it, which is the control part, which we are hoping more and more people get vaccinated. And then the reframing, that's where it comes down to, that this is the best we got in this situation. What can we make most of? It's like putting more quality of time with our kids, since there is, they have isolation. So can we be more present when we are together rather than checking our phone, something of that nature. Some skills of zooming in and zooming out can help. Sometimes we are just so zoomed into the news, the New York Times, the number of deaths and all that, that we lose the perspective that there's still so much good. So it doesn't take away the bad, it just helps us resettle and then do what we need to do. I kind of think of when Second World War happened, that's when Einstein did the most research, which physics has grown so much and we are all benefiting. So part of us using our brain to our best capacity and not letting everything get drained out is one of the things we've tried to use. Of course, we are all humans, and the load of information gets too much at times. So just compartmentalizing, some of those ideas. Yeah, everybody has, I think, lots of pearls to share. These are some of the thoughts that came to me.
Great suggestions. I love that. And I think the more we can, like you said, compartmentalize, don't let all that information overload, create more undue stress on you, which it can do that. And many have faced that. Dr. Kumar, what are your thoughts? I mean, you've seen this. This is a great sort of a way to end this conference, this session, but also what could we do next as future topics as we think about this pandemic and how we can maybe help our community? What are your thoughts?
Yeah, first of all, I want to thank the talented panel of speakers who volunteered their time and expertise on a Sunday afternoon for us. So thank you to all three of you, Dr. Chakraborty, Dr. Kolla, and Dr. Sood. Your talks were amazing and fabulous. And thank you for putting on all the effort. I then want to thank Dr. Pruthi, who did a beautiful job moderating these talks. You were just fabulous. So we do want to get input from you all about how we can do better. There's a survey link in the chat box. If you can really put your comments in there. There are 2 questions in the survey. One is what topics you would like to hear. And the second relates to the frequency of these seminars. And the whole point is to provide education to our community, and we want it to be relevant and timely. And all the speakers did a beautiful job today, but we look forward to your input. We really want your input, and we hope to improve our program with your input. So that's one. Finally, I just want to thank the team that made this event possible. Dr. Kadirwal and Dr. Sabhalwal from the communication team spent a lot of time behind the scenes. So I really want to thank, if you can put on your, put your video on, Dr. Kadirwal and Dr. Sabhalwal, for all the effort that you did. So thank you. I also want to thank other members of our ICAM Health Committee, including Nisha Kurup, Dr. Pruthi, of course, Dr. Prasad, and Dr. Bhagra, and finally to Ajay for leading this association. So thank you again, and thank you for joining us today. Hope you'll have a lovely evening and stay well.